limited access to life-saving surgical services. There is a heavy surgical workload for those who are undertaking surgical operations. There is a high maternal mortality rate. There is a high case fatality rate for injuries and other surgical emergencies like intestinal obstruction. There is a high prevalence of surgically preventable disabilities, and there is unnecessary referrals to national and regional referral hospitals. This project is therefore focusing on the use of task shifting to expand the provision of essential surgical services with the ultimate aim of increasing access to high-quality, life-saving surgical care, among other activities, piloting a training program for non-surgeon physicians. These are the medical officers, and non-physician clinicians, these are the clinical officers. The project is trying to answer the following questions. How can we improve access, quality, emergency, and essential surgery for the people of Uganda, given the shortage of surgeons? And also, how can we improve the productivity and quality of surgical outcomes at general hospitals and health center force, now that there are medical officers there and clinical officers, and expensive theaters have been built there. Evidence available shows that in Uganda, general hospitals and health center force already do carry out surgical operations. They are carried out by non-surgeon physicians and non-physician clinicians without further training. In a survey in 9 hospitals in Uganda in 2008, we documented that surgical output had not changed over the past 10 years, although the population had increased and therefore the demand had increased. The average number of surgical operations per hospital per day is 3. The causes of such a low output include human resource shortages and capacity. During a situational analysis for this project, carried out in 25 hospitals and health centers, we established a desire among medical officers for surgical skills development. This desire has been demonstrated by their participation in the essential surgical skills training workshops that we have conducted. This is now being followed up with mentoring of medical officers and their surgical teams in essential and emergency surgery. We expect that this will increase the output, therefore make better use of available human resources, and make use of the many redundant theaters that are not operating now, improve access to surgical services, reduce mortality rate, and reduce disabilities attributable to surgically treatable conditions. The project is working to cover this skills gap and to improve the quality of services provided. In summary, the expected benefits of this initiative are multifold for Ugandans at different levels. 1, save lives lost due to unrelieved obstructed labor, intestinal obstructions, and road traffic accident. Number 2, prevent disabilities due to essential surgery not done. Number 3, make better use of available human resources. Number 4, utilize dormant theaters at general hospitals and health center force, which have cost a lot of money to build. The project is being carried out in 25 hospitals and health units in several districts like Mukono, Mityana, Mubende, Masaka, Bugiri, Rakai, Iganga, Mpigi, Kayunga, Lyantonde, Kiboga, Nakaseke, Wakiso, Luwero, Jinja, and Serere.